talk to you about core measures. We're still hitting our targets mostly. We have our deficiencies, most of which are in antibiotics and beta blockers, but we're making progress. Why are we doing this? Dr. Cat said so. Daly and Larson are less than enthused, but they're the anesthesia champions, and Daya is still getting beat down pretty good about it. So she's passed that on to me, and I am working on improving our knowledge about it, just keeping sure that we always are keeping this skip in the back of our minds. And more importantly to me, I think that we're doing this for all of our patients, that we're not just doing it on those that are going to be audited, but that we're doing it for everyone. Our goals here are really to reduce the morbidity and mortality of our patients that are having surgical procedures. Doing that the best we can by following evidence-based practice. Who came up with these rules that we're being forced to follow? As far as nursing goes, we have the AORN, which I think is a respectful organization that does a pretty good job. There's several of the physicians' organizations along with CMS, the CDC, VA, JCO. People that have good research dollars who've done this to find the evidence-based practice and find broad goals that can be implemented nationwide for academic and community hospitals throughout. Who is a SCIP or HOP? The HOP is the outpatient, but they still fall under the SCIP Surgical Care Improvement Projects. So these are not PDs, they're not TOGAs, they're not Mr. Buzek, they're not pre-existing VRA, MRSA, they're not burns. Traumas, I wonder, what makes it a major trauma versus a moderate versus a minor trauma? So that could be a tricky one. And then none of our serial washouts that are coming in daily or every other day, they're not included in as far as the auditing goes. Surgeries, if the patient meets the previous criteria and they're having one of these procedures, they are definitely going to be audited. That's all of our vascular cases, so HBI is on red alert. Our hips, knees, hysterectomies, whether it's open or laparoscopic, it's included. And of course the colons. Beta blockers, VTE, and hair prep are for all surgical cases who meet the previous criteria. But we know that this is a standard for all patients. Whether or not they meet the certain criteria that qualifies them for being under our audit protocol, we do want to make sure that we're doing the best, highest level of care. I think that from a liability standpoint, that's something to look in place. If we've been educated that these are standards of care for these patients,
but aren't the
why
beta
not for
blockers
others?
For heart patients?
The beta blockers are for anyone who is on a beta blocker at home, has been started on a beta blocker since they've come into the hospital, or has known coronary artery disease.
Right.
So those patients have to receive a beta blocker within the perioperative period, which they time as 24 hours prior to surgery, during surgery, or before they sign out in the PACU. When we get that vital sign stable okay to the floor, the perioperative period ends as far as their definition is
So if they
concerned.
take one at home night before surgery,
They usually take them in the mornings.
We're good. And we tell them that, you know, take your blood pressure, any anti-rejection drugs, you know, it's okay to take those. So we're doing great with that. But what about these in-house patients who, they're on a beta blocker at home, they come in-house for a procedure, the doctor doesn't reorder it for the in-house meds. Anesthesia looks up their pre-op information on the computer, which it's not on. Home medication record's not on the computer. They don't see it, they don't give it. Patient has some kind of CV compromise post-operatively. Was that due to the additional risk of us not following these standards? You know, there's all these loopholes that are existing, so we need to be vigilant in just asking, you know, following through, looking at that pre-op on the anesthesia record. Was there a beta blocker? Did they give it during the case? Do we need to ask them to order us 1 milligram of metoprolol to give in the PACU?
5 beta.
You know, what can we do so that we're at least covering the bases, and if nothing else, covering our behind.
Every beta, that's not a problem.
So the antibiotics are a big deal. A lot of the, you know, starting off falls on surgery, administration falls on DSU and anesthesia. Discontinuing, we have some involvement here. We have the problem in that pharmacy doesn't look in the computer. They say they don't have the staff to look in the computer to find the surgery stop time or what time the antibiotics were given during the case.
Why can't they just order it by dose? I mean, doesn't that make it just as easy? 2 doses after surgery?
Well, the thing is, what time? If they have
you have to
get,
make sure that they don't give it at the 25th hour. So
Yeah,
that's why we were writing that surgery.
they have to get all 3 of their doses before the 24 hours
Right.
from the surgery stop time. So once we finally embedded it in everyone to write that surgery stop time on the post-op orders, just to warn you now, in October, it's going to change to anesthesia stop time. I did an informal audit and found that only 66% of the time was the surgery stop time indicated on the anesthesia record, whereas the anesthesia stop time was written 100% of the time.
So go by that, we'll make
Because
we're
they
more
told
likely to-
anesthesia that they didn't need to write it anymore, that they just walk away with, they write their walk away time.
And
what
that's usually
anesthesia is.
in PACU. That's
Right.
so
Right.
basic as PACU.
And so we're going to run into trouble in October because I don't know how they're ever going to, the OR is ever going to know what the anesthesia stop time is, all of these things.
They won't.
But I want you to expect those changes, to know what we're currently working with and what to expect in the future. So I encourage you to continue to write the time that the antibiotics were administered in the OR so that they know 8 hours from that time. Give it a report, write it on the orders, whatever you need to do.
I've done
And
a
also
lot
write
of
the
the,
stop
they're just
time.
not ordering antibiotics after surgery anymore.
Which is fine, and I just
I mean,
write
that's how-
no antibiotics per surgeon, or don't write anything. But if you have the information, pass it along. Or pass along that you don't have the information, and maybe the next nurse will have greater access.
Sometimes I just write it on the
The
order
simplest
sheet.
thing to actually do to fix that is instead of, I mean, anesthesia gives the antibiotic in the OR. The OR nurse could actually put it in the computer.
Yeah, I think they do. They
Right.
used to have
And
to.
so if it's in the computer, then it's
Then
on
there's
the
a reason.
patient's MAR. So when the
That's a big
patient
way
goes to the floor, that's going to
No,
print.
it's not on the MAR.
It's not on the MAR,
Why
it's
wouldn't
just
it
on
be?
It's
the,
on the intraoperative report.
But I mean,
And they
why
don't flow over.
won't they be able, because if a medication was administered, somewhere it needs to be in this computer that medication was administered.
Yeah,
Why
but
are we
it's like,
still
it's like
using
when we
paper?
give drugs here, they're not, I don't think they show up on.
Yeah,
show
they
up on the
do.
MAR.
It's
Yes,
on
they
the
do.
MAR. Anything that
Well-
patient got should be on that patient's email.
What I used to do, and I've gotten bad about it again, is when I would look at the orders for the floor, I would just write beside the antibiotics last dose
That's
given
dose
at.
given.
LD
Yeah.
and
And
the
that
time.
way it's right there.
Right.
and I think that yes,
when
is
they- when they
additional
put the
work for
orders in.
us, but it is helping to ensure that these patients are getting the
Yeah.
standard of care.
In a timely manner, yeah.
So,
But I found that to be the easiest, that way when they took the orders off, they had the information right there.
right.
Especially if the nurse happens
And
to
that
look
gets
at
faxed to,
That goes to the pharmacy.
And
that
the
gets
pharmacist,
faxed to
so
the
they get it as
pharmacy.
well.
And that, because the nurse might not see those orders till midnight.
yeah.
So
but-
that's word we need to spread. Getting help from the OR circulators is important, as encouraging our peers to take that extra step, I think is important.
And you have to double check if they've been in the OR for a long time, they've got multiple doses.
Oh yeah, or maybe they forgot that second dose and it's due probably on arrival to the PACU. So really keeping that in the back of your minds. It's great. Cardiac surgery patients, they want their glucose less than 200, 6 a.m. the next day, or 24 hours to 48 hours afterwards. That's going to be a big challenge for HBI. Appropriate hair removal, the OR is doing
Let me
fantastic.
stop this for a second.